Jaydeep.
Yeah, good morning. Thank you, Dr. Pillai and AIOS for having this case here. So I'll just quickly go through I think Aishwarya has presented the case quite well, and I'll just go through the discussion part. She was treated with, she has not covered this, but she was treated with anti-VEGF injections, and she responded quite well to the injections, and there was good resolution, and she at last follow-up, she is 6/6 and 6. She came this week, so it's been a 1-year follow-up now. So what I wanted to highlight here is that at that point of time, this was June last year, we hardly had any case reports or any cases where retinal vascular occlusions were noted after COVID-19. We had a lot of case reports where systemic vascular occlusions have been found and thromboembolic events were known at that time, but we did not know about any retinal vascular occlusion. So especially in a young patient. So this is something which we need to keep in mind when we are, especially in this COVID era, when we come across any vascular occlusions of the retina. And subsequently, there were cases which were reported in India as well as elsewhere, which with CRAOs, CRVOs, vasculitis, and so on and so forth. So it's an important thing to keep in mind when we come across patients who may be asymptomatic like this one and may not reveal history of any contact with COVID-19 patients or themselves having been tested for COVID-19. So the possible mechanisms could be the way it is systemically. One could be inflammatory response, that is after the cytokine storm. The other one could be just increased thromboembolic phenomenon secondary to the acute phase reactants like D-dimer and LDH and ferritin increasing, causing a hypercoagulable state. And lastly, it just could be something like a vasospastic event, which is temporary, because this patient improved very, very well. I mean, it was not something which we usually see with a CRVO recovering to 6/6. So this could be the possible mechanisms. So the question is, should we keep in mind testing for COVID-19 or for all patients to present to us with retinal vascular occlusions? And is there any rule of putting these patients on any prophylactic therapy for preventing vascular occlusions in other parts of the body or the other eye? Normally, we know patients who are morbidly ill and are in ICU with COVID-19, they normally are put on these. But what about these asymptomatic patients? Should we consider putting them on anything? So these are the questions to the panelists. Thank you.
Thank you very much, Jaydeep. Thank you very much. You can stop sharing. The first question that I would like to ask before we address Jaydeep's questions would be, is there any difference in the vascular blocks in a COVID positive situation versus the other usual situations?
No. But the first case I saw last year was actually a combined CRVO with a BRAO. So combined blocks probably can occur in these patients. But after that, and then you have the whole spectrum. So after that, I have seen patients with early venous stasis retinopathy as the other end of the spectrum. And you can have patients in between with only a BRVO or only a CRVO. So all these forms of blocks will be there. The important thing is, keep in mind, these are younger people. See, when it occurs in a 60-year-old, you don't bother about the etiology. When you get it in a young patient, it is, and you have to look for some kind of inflammatory pathology, or actually what the whole panel is, look for causes of congenital or acquired hypercoagulability states. That is the statement. Now, basically, any patient who presents in this age, the panel which you've done is actually not a complete panel. The complete panel includes, and this is what I tell in all my residents, it's protein C, protein S. These are for congenital hypercoagulable states. Factor V Leiden. And then you come to homocystinemia, and then you come to anti-phospholipid antibodies, especially the cardiolipin antibodies and lupus anticoagulant. In fact, even for COVID, you should look for anti-phospholipid antibodies, because the mechanism is through that. It's antiviral antibodies which end up creating this hypercoagulable state, and then this whole process starts off. So it's the COVID antibodies give us the clue that this is related to COVID. you will not have a positive COVID test, antigen test at that time. And then the other causes, the importance of these is because if there's an inflammatory pathology going on, steroids would work. You don't need to give anti-VEGF. In fact, what the question I want to ask, after the first injection,